I'm Hall Griffin. I'm with IMAX Veterinary in Longview and happy to be here at Memorial St. Augustine today. I've been tasked with an introduction to external skeletal fixation, which isn't as easy as we plan. But the goals today, I think, will be to give an introductory vocabulary, let people share a common vocabulary, get some mental images of the items we have, of the frames we have, and hopefully I really would like to open up to questions, especially with sales team groups, because I'm more accustomed to giving these talks to veterinary surgeons, veterinary residents, and others. So I'm trying to shift my teaching direction down. So feedback would be very good. So the question is, what's external fixation and what comprises external fixators? And we try to keep that simple and say any application of pins or wires through the soft tissue to engage bone. And we think of fractures, but certainly joint arthrodesis, joint soft tissue injuries, and I've even seen external fixators used to support soft tissue expansion grafts and things. So any sort of external support or column or frame for whatever purposes it's used for. And yes, we can combine external fixators with intermedullary pins, lag screws, cerclage plates, and other applications. So advantages of fixators that I like to bring out for people are they're economical. Many of the components are reusable. And in my mind, if there's a general practitioner or somebody that's using ion pins and wire or wants to expand their orthopedic capabilities or simply get into long bone orthopedic experience with a minimal financial down payment, that's fixators have to be. You know, from a biologic standpoint, we're certainly favorable to closed or minimally invasive application, which is many of the buzzwords today in fracture repair or biologic technique. And that's supported for the fact that the hardware is located away from the patient's limb, away from the fracture zone, away from the biologically active healing area, and more favorable that way. And we have, within reason, but reasonably reasoned, ability to reduce just fracture reduction and alignment during application. And I say within reason, certainly the closer we get to the frame being finalized and all the pins in, we progressively lose that ability. But it certainly is unique.
What is the infection rate associated with external fixation compared to internal fixation? Is it comparable or?
I don't see many infection rate studies. Most of them are old. I would say they're comparable.
Okay.
I think both of those natures and modalities we're learning to reduce infection rates with biological technique and less manipulative methods.
Awesome. Thank you.
And again, rigidity can be adjusted to healing or changed during the healing period, which is very unique to fixators. We can pluck off or remove a portion of a frame or some pins as the case is progressing, if so desired and indicated. And obviously, external fixators are very easy to remove. We don't need to go into the OR and do a surgery. Usually, sedation, heavy sedation in the prep room, but using good clean technique is adequate. So while I love fixators for their many advantages, we have to admit with any system there are disadvantages, right? Mm-hmm. Okay, so let's look at some of those. When we place pins and wires through skins, muscles, we can hit things like nerves, tendons, vessels, so we can cause damage and cause discomfort. Obviously, people worry about the pin tracks being a source for bacterial contamination, so that's obvious. And we talked about the advantages of the hardware not being at the fracture zone, but distant to it is very biologically favorable. Mechanically, that gives it a disadvantage. So I always talk about also post-op care with wound tracks. We do it. I enjoy it. Some people find that they really get good interaction with owners. but we've got to recognize it's going to take more care. It's not out of sight, out of mind. Okay, so what do we do? We'll go over that real quickly, but let's find the things that are disadvantages to be aware of them, avoid them, or when we can't avoid them, properly manage them. Let's use the advantages to our benefit or our patient's benefit. And most important, we aren't a one pony show or a one trick pony or whatever the term is. We can combine systems and we maximize advantages of each system. And for example, the plate rod on the left. Okay, I don't know why surgeons call it a plate rod when it's a plate IM pin, but those are combined systems and cerclage wires, central picture, humeral fracture, combining IM pin, cerclage, and external fixation. And yes, occasionally we've combined external fixators with interlocking nails in problematic scenarios. That said, I want to dispel the myths right up front. The myths are that external fixators hurt, that they cause pain, that you shouldn't be using them. And that was disadvantage number one. We talked about learning how to avoid or work around. So if we look in this case, I have a young person playing in a swimming pool and a duck swimming in a pond. They're comfortable. Young lady riding a horse with the fixator on, comfortable. Comfortable dog, looks happy to me. Patagonian cabby that moves around really well, and a child that's posing for photos with a smile on her face. So that's the goal of external fixation. And when that fails, I don't know that it's the fault of external fixation that failed. It is this technique and decision making failed. So we also know we can replace total hips and leave patients uncomfortable. We can repair fractures with bones and nails and leave patients uncomfortable. So regardless of what devices and systems we use, we want to use proper technique and proper decision-making processes. So that's the myth I'm here to describe today. I will show you an image later where we didn't do a good job. So external fixation frames, we've kind of got three flavors here. The linear, and linear is a word we threw on external fixators years after the fact. We used to have external fixators and we thought bar, connecting clamps, and pins. And then as we evolved into circular fixators and then on the hybrid, we had to come backwards and put a name on linear. So linear, just think the traditional standard external fixator. The circular fixator in the middle is historically Professor Lazaroff and post World War II Soviet Union developed this, and then people caught on over the world over time, and then eventually one of his deputy directors moved to Dallas, Texas, and worked with Texas Scottish Rite Hospital for Children, and they also had a veterinary surgeon named Bob Welch on their research staff. So we got into circular fixers, and ultimately that led us to the role of hybrid external fixation. And we'll get into those definitions and terms a little bit more. So if we go back to the linear frame, they're really simple. We've got pins, external bars, and clamps. So we've got mainly something held into the bone and then something exterior that holds that bone in spatial alignment, gives the patient a comfortable something to walk on, a comfortable, stable fracture repair. And again, I'm using fracture repair as examples, but we do limb deformity corrections, support ligament and tendon injury repairs and things. But again, the goal is comfort. The goal is getting things where they need to be. The circular frames are very similar. When you really look at any external fixator, it goes back to that concept of wires or pins through the skin interacting with the bone and something on the outside that holds it all in place and stable. Circular frames are a little more complicated just because there's more parts, more hardware involved, and take time to put on. And we do that when we need what a circular fixator can do. And right now, they've relegated themselves into some very complex limb deformities that lengthening of the bone is needed, or pure lengthening, and some perhaps bone cancers and where we can actually grow bone. We'll get into that later. So if we look at hybrid fixation frames, pardon me, yeah, you know, it's you look and you see something that looks like a circular fixator, you see something that looks like a linear fixator, and for veterinary surgery, that's enough for us to call it a hybrid frame. Some of the human surgeons will argue there's a lot of nuances, and some of their circulars would be called hybrids. But thinking when we say hybrid, that's as good a picture of it is. A minimal ring and obvious linear components. Those are really nice for juxtarticular fractures or fractures with very short fracture fragments that even with locking plates, they're hard to grab, hard to control, and yet it remains user-friendly and economical compared to the circular fixator. So hybrids are the popular, more complex frame. Again, it's repetition, external columns and things going into the bone to maintain the alignment of the bone, protection of a joint or other applications. And so big dog on the left, little rabbit on the right. Sometimes the patient's bones are so small that we use miniature fixation pins in some sort of acrylic frame to do those, and getting into microplating and things like that to handle those. So let's talk a little bit more about definitions, just because I want us to be able to talk onto the phone. You talk to your customers and have a vocabulary that kind of works across borders, works across languages, and really makes it easier to have a conversation. So we talk about external fixation pins. We divide those into two major categories: full pins and half pins. So we haven't said anything about are they threaded or they diameter or anything, just the general term full pins and half pins. So regardless of full pin or half pin, the pin engages both cortices of the bone. Okay, so it really needs to be stable. The half pin only exits the soft tissue on one side and therefore has one external bar in general connected to it. Full pins, again, both cortices of the bone, always, but they also exit soft tissues on both sides of the bone. So full pins, most commonly in modern day terms, are centrally threaded positive profile pins, and half pins are usually end-threaded, either positive profile or Duraphase type. So we'll have a separate pin lecture later, but right now we're laying that groundwork. And so modern fixation pins is it, and we'll explain later why non-modern pins aren't good. So if you ever hear a surgeon that's frustrated, has a problematic case, and says, let's put a Kirschner on, or let's use a Kirschner, what's that mean? I don't know if that language is still out there. Do you hear that? Okay. So the Kirschner is a company that was around 30 or 40 years ago. They had a small veterinary division, and they pretty much were the only people to make external skeletal fixators for animals, at least in the US. And that use of the term Kirschner has become somewhat synonymous to Coke and Xerox. You know, say, hey, let's run this down and Xerox it, right? Or make me a Xerox. So Kirschner has become a generic that mainly means external fixator. And I'm glad you tell me that it's still around, because I'm getting where that term's dying away. So be careful if one of your customers says, I'm going to put a Kirschner on this, or can you help me get a Kirschner, that they aren't thinking Kirschner brand, they're thinking external fixator most of the time. And if they're still actually using Kirschners, you need to be converting them. Okay. So let's see. So are there any questions to date on simple while I grab a drink?
Did we get a copy of this?
Yes, it should be up and recorded. Okay, thank you. So we're going to talk about classifying external fixation frames. So there's old things, a lot of surgery residents and things get to publish, and it gets complicated, especially since a lot of the data is old and the new hasn't been put in. But I want to talk about classification of frames for two reasons. And one, we know mechanically, the more things get complicated, the more components, the more bars, the more full pins, stronger we get. But we also know the more and more and more holes in the skin we place, the maybe less comfortable we get. So it's a trade-off. But today's take-home message is I want to forget mechanics, and I want to keep frame classification, or what frames are called, real simple. And the reason we do that is if one of your customers says, I would like to build an 8-pin type 1B, you don't have to spend 2 minutes asking him how many bars are in there, how many pins are in there, what type of frame you want to build. You know right then he does not need full pins. Okay, you know 2 bars are needed. So you're really narrowed down the conversation. And if they don't know this, or customers don't know this, they catch on it rapidly. It's when we try to teach all the minutiae of why we call them that and how they behave that term gets lost. So let's just look at frames. Okay. Type 1A, simplest frame we've got. That was the original. You'll hear the term half pin splint, and you'll hear the term half Kirshner. But that's the frame. Okay. By saying type 1A, again, you have a vision that says single bar and all in threaded pins. We can redefine that on what size bar, what size pins, how many pins, but the 1A is the simplest out there. 1A tie-in, very often when with fracture repair of the femur and fractures of the humerus, where external fixators are used, most commonly we combine that with an intramedullary pin. And in that case, very frequently, we will link or tie that intramedullary pin into the external fixator. So that's nothing but the 1A you just saw connected to a 9 pin. So 1A tie-in. 1B is a frame that I truly love, especially on fractures of the radius. It's going against what we were taught for a lot of years, but it's much more functional. So 1B, the best I can describe it, is take 2 1A, put a 1A on, put a 1A on, and another plane, and that's a 1B. So still all half pins, no full pins. This picture shows some connections between the rods, and that's a simple, easy frame to build. You'll see frequently. A type 2 frame, you'll hear the term full Kirshner, and I use the term loosely Securos mentality. But now we're in frames that use full pins, or we have frames that pins that connect on to both ends to bars. So these are more difficult to put in, require very often some added aiming device and instrumentation to work with. And so, but type 2 frames, this would be a maximal, so to speak, because all the other pins are full pins. And we can have minimal, anything in between, as long as there's at least one full pin in each major fragment, proximal and distal in this case, then it's a type 2 frame. So what do you think? Okay, type 2, you think, okay, my customer will need at least 2 bars, right? We'll be looking at full pins and maybe looking at half pins if they choose to do something a little easier, which would be a minimal type 2, meaning enough full pins to categorize itself as a bilateral or type 2, but a minimal number, so there's less soft tissue tracks. There's less need for aiming and accuracy. So these are much easier to build, especially with older historical hardware. Type 3s, I hesitate to put the image of because they're monsters. And back in the days with poorly designed mechanical systems, even then we wouldn't use many of these. But now it's somewhat unnecessary, unheard of. But sometimes we do use these other bars and other planes because a fractured piece of bone may be so short that we can't get the number of pins we want in one direction. So coming to another direction and using another bar to provide space and provide something to anchor something that that there's not room for on the other one. The other thing I hear is if you ever hear some human guy talking about building a Delta frame, this is what they mean. And to the best, I don't know where Delta comes from, but it seems very rarely used and only a small version of it for problematic cases.
What would be considered a problematic case?
In my situations, to think in terms of that kind of frame, full pin, half pins, 3 bars, my problematic case would be not so much the breed, the age, etc., but a very distal fracture. And maybe I don't have the right locking plates or don't want a double plate. I don't have hybrid or circular, and I need to make it work with bigger pins. So the problem to me is problematic is getting 3 pins in a short piece of bone. And so I'd use this type 3 orientation to get there.
Gotcha.
The only true cases I've seen where people actually build this type frame with IMEX SK parts, they've been putting our larger fixator pins on folds and calves and things where the patient is just physically bigger.
Gotcha.
Significantly physically bigger.
Thank you.
Okay, you're welcome.
I wonder if they call it Delta because it's triangular.
I'm thinking that, I was wondering that on the plane on the way here. Isn't that the Greek?
It's the Greek symbol
the
for-
Greek delta?
yeah, it's
Yeah, and I'm thinking that may be it. So
I-
can we
I had a friend
vote?
in college who was a tri-delta. I just remember they were 3 triangles.
So can we
I
vote
was
that
like,
that's,
maybe.
that's official now, right?
Okay, works for
Okay.
me.
Good. Because I had a guy asking that, and I couldn't answer the question. I mean, he was asking me, a human guy calling up, wanting to know if they could build a Delta frame with research with our components. I'm like,
Sure, why not?
what's a Delta frame? So let's look at target customers. Early in the deal, I think of general practitioners that are in practice. They want to start adding to their fracture capability. Maybe they've got pin and wires and they're starting to recognize the limitation of pin and cerclage. Maybe they have basic ortho instruments. Maybe not. They just want to start. But the good thing about X-Fix, it requires really a limited amount of instrumentation. It is obviously best to start, maybe not obviously. We like the radius and tibia as learning bones because we just stay away from all the heavy soft tissue movement and all those things that cause discomfort. Or maybe they're a practice that's doing a fair bit of plating with your components, but they still have these cases, the open contaminated injuries, transarticular problems where the plate alone or the plate can either make things worse or is just a real workaround. So I think from that standpoint, general practices, you've kind of got entry levels, you've got people that are pretty good customers, but they're seeing the need now and then. For the surgical referral practices and academic teaching centers, they've got all the implant systems. So what do they use external fixators for? Certainly less than the rest, but commonly open contaminated injuries are really great. They see a lot of tendon and ligament injuries, Achilles injuries, where transarticular fixators, although they're challenging, can really help. The juxtaarticular, the very short fracture fragments we talked about, Corey, you talked about a type 3 frame. Sometimes it's hard to get 2 or 3 1.6 millimeter wires. So the type 3 frame goes out and the hybrid comes in just because of the tiny nature of the wires allows people to capture a piece of bone that's very, very small and still have a patient function on it. And that's where I see a big part of the surgical referral situation going to. They're just cases you can't nail, cases you can't plate, and cases you can't do with a normal fixator. So the hybrid steps up, and we'll talk about hybrid a little more. And then also they're very useful for deformity corrections, and many of which are done with locking plates, but especially when those deformities have a whole lot of torsional rotational component to them, which is really difficult to deal with plates, they become a really nice option.
I think your corgis or your like mini pits that have really wonky legs because they're mixed with lots of other things for the angular limb deformity. Like when they have like those short stump little legs and you have to turn their feet, that's when that's going to be really, really helpful.
Exactly.
Okay.
Okay. So let's see. So let's talk briefly about economics and kits. So I put a picture up. I don't even, that would be the small SK kit. We'll talk about the specific sizes next talk in some more details. But so all of our starter kits are basically the same, a variety of lengths of external bars. So you can handle short dogs, tall dogs, the crossbars between frames. We will typically put 2 pin diameters in those kits with more volume loaded on the end threaded. If you're getting a feeling that we don't like centrally threaded pins as much as we did 20 years ago, you're probably catching it right. And we'll walk through some of that, but we still use them. They're still great. And then we like to pre-drill pins. So the appropriate drill bits are in there, the wrenches. And so that starter kit kind of lets you do when the customer calls and they're needing their first case and they haven't got it yet. I'm kind of like, instead of you and I going through and counting clamps and talking this, do you want to, if you want to build a 1B, you can do it with this case. If you want to build a minimal to a mid-range type 2, you can do it with this kit. And we kind of talk a little bit about the pin diameter, make sure we've got the right kit, make sure they aren't trying to do anything. So this is current list price for kits. So, you know, to me, I go back to that economical next step for the generalist, and I look to the academic centers and referral centers of saying, you may be using this, but when this was designed, we also kept in mind the circular and hybrid fixators. So guess what? You don't have to go buy other stuff. This is modular, the same tools when possible, certainly the same clamps, same pins, etc. So it gives the referral type practice a lot of upscale or up buildability with the same, like I say, they don't have to go, okay, here's my linear, and now I've got to go buy a hybrid and put it over here. I've got to go get a circular and put it over here, because they're all designed by the same team and the same goes. So that really works well. What questions here? Anybody else have some questions here? Thanks for the breed specific comment there, right?
Do we have any questions from the team out there too?
I have one. I'm not sure if it will come up later, but it was regarding the 1A tie-in. I was just interested in what bones that's typically used on. I think you showed it on a femur, which makes sense to me. Would there be other bones?
The other bone would be the humerus. You know, much like the femur, those are both bones where we're working up higher on the limb and more soft tissue. And more particularly on those bones, we lose the ability to put pins in other directions, because I don't know if you can see my leg, I don't want a pin here. That hurts. I can't walk. Where if that's the tibia, I can put pins here, radius all around. And one of the things we give up mechanically by being a single bar frame is some bending. And the IM pin really helps counteract that bending and does so without additional holes in the soft tissue, so to speak. So humerus and femur are the answer. Tibia could be done, but there's just so many options on it that we would rarely see that. And the radius, to me, it should be illegal to put an IM pin in anyway.
Thank you.
Did that get your question?
Absolutely.
All right, thanks so much.
So what does CE look like? Is that something that's in person? Is that like, what does the CE look like?
One more time, please.
What does the continuing education look like to, if somebody was going to learn like the
Okay.
system?
We need to work with you guys to restart. So our linear course that we did for years and it's kind of petered out really starts with just the basics of what we're talking about: frames, how to pre-drill, how to properly tighten clamps, and really expands from those basics of what I call the hand-eye work to really the decision-making process. So I want to tell you something that I don't want to offend you, but I think it's true, in that external fixators to me are really fun because we're building a frame that's custom for my patient. I'm making decisions based on what the owner's like, what kind of care they've got, what kind of health this patient in, what other limb injuries are there. And I say I don't want to offend you. To me, it's much more of a thinking game than putting a plate on, where you look at a chart and you look at a bone and you put the plate and feel how many holes you can. So a lot of answers we deal with there, or the second part of those labs, where it doesn't take long to learn to use a wrench, to use a drill bit. What takes more time, and we walk through lab scenarios of, I'm going to give you a patient of this age, this breed, this weight, and tell you something about their owner and their environment. And you're supposed to ask questions like, so how are his other 3 legs doing? You know, got hit by a car. How many times have you talked to the veterinarian? Yeah, I need help to put this on. And then he says, after you make that decision, well, his hip's out on the other side. You know, it just changed the whole equation. So I think the second part of that education is, okay, now if you want more and more challenging cases, we've got to teach a more and more detailed thought process. And then trying to get in early users to stay below the elbow and the knee, because that's really a much more forgiving area.
What do you think their comfortability is after like how many procedures? If they've after course, or like if they've done how many, do you think that they're really in their groove?
Good question. Because if they aren't stepping out, if they aren't overextending themselves first, I think you can get in the groove pretty quickly with radius and tibial fractures. I think we get in trouble early with the comminuted femur, that I don't know any of us ever get into the groove on that one. We'd rather use a nail, rather use a plate rod, but sometimes it's all we've got, or there's an extenuating circumstance, and those I think we're all somewhat uncomfortable with, and pulling that as the last option. So if everything came down right, I would say 3 to 6 cases on the lower limbs that weren't overly challenging. But the problem is, and you may have seen it, and it's regretful, but it's reality, is sometimes somebody's already tried to refer this case twice, and that's not an option. And now they're going to do something. And I do the best I can help them, or I do the best in some cases to talk them out of it, because it's just going to be a disaster. But down here, I think very friendly.
Awesome.
Good question. Thank you.
Yeah, thank you.
So I have a question. You mentioned at the beginning that some of these parts are reusable. So aside from the instrumentation, would that be like the bars and the clamps? Are those reusable?
As far as what's reusable, I just want to repeat and make sure, you know, the question is which components, if I summarize it, which are reusable. We think pins are never reusable. One, they're the component that's in there getting loaded and flexed, and every time the patient walks, and therefore that's the fatigue prone area. In reality, you've cut them short when you're done, so they're no good. Wrenches and tools are normally reusable. The question becomes external bars and clamps. And I think most people that I know that are expert external fixer users reuse those, as long as they look well enough that they aren't embarrassed for the owners to see the part.
Okay, so there's not as much of a concern then with it being like load bearing or worn down.
Not really, but I think you're seeing that with the wear, but you don't see to date. Now, I know there is one report that makes it sound like you should never use anything more than once, and you can make the academic argument, but the people that used to teach our course that we need to rejuvenate, they all reuse regular, as long as it looks good.
Do you know about how many uses?
No.
Okay.
We made a lot of circular components for the hospital in Dallas, Children's Hospital, because they did goat surgeries, and they used them over and over and over and over. So I'm happy as long as they look good. The aluminum clamps, they're going to start showing, you know, some appearance and some degradation. The bars, sometimes the end of the bar, carbon bars, especially if the surgeon left them long, are going to get some pounding on the end and some fray. They're time to go. They're time to go. I like this group. This group asks a lot of good questions. Thanks. It makes the job much easier.
I was just going to jump in and piggyback on top of that, because I came from a clinic and we used IMAX external fixer stuff quite a bit, and the clamps will come apart. So like you have like where the carbon bars go in between them, and there's a little nut on there that those nuts and washers come off. So you can break them completely apart to clean them and sterilize them so that, they are going to be able to be reused as long as they're in good condition. So that makes it nice that they completely come apart and you can take those brushes and, get in there and get all the, tissue and goo out.
What's your experience? How often do you use them?
We use them pretty regularly. I wouldn't say, once a week or anything, but twice a month. The hit by cars that are, open Achilles injuries. We had a patella fracture that we used a fixator on to make sure that, they weren't gonna ruin the fixture of the patella itself, because we had to literally take cerclage wire and put it back together. It was in like 4 pieces. So we used the hinge and locked the stifle in place so it couldn't bend while the patella was healing. So lots of.
And that was a referral practice, I'm gathering, with the patellas, and
Yep.
and that's kind of what we see. We see the referral practices gravitating there for those really problematic cases where they just need to either reinforce what else they did, or they don't have a good option. And then sometimes, especially with the hybrid and circular, going that route as well.
Puppies too, because they heal so quickly. A distal femur in a puppy, couple pins, and you're good to go.
How accepting are the patients of external fixation?
Pardon me?
How accepting are patients of the external fixation?
I go back to the pictures I showed you.
Yes.
If you do a good job and they're comfortable, especially lower limb where we don't have so much high motion soft tissue, I expect them to be comfortable. I expect them to be like that. I don't want my patient out swimming in the Florida pond across the street, but I certainly don't mind a swimming pool, a water treadmill. Other than that, I tend to avoid those kind of water treadmills in rehab facilities because you've got an open wound, and I just as soon not do that. But if you want to go home and shower and play with your hose, great. Just don't get
Right.
the darn dog that just used this swimming pool. So I expect them to be comfortable. And one of the most frustrating things is to talk to a veterinarian that says, this patient just wants to chew on this fixator. He takes the bandage off. And I'm like, so what do we need to fix? We don't need to give him ACE. There's a reason. And typically it's going to be soft tissue impingement on a pin. If we can sedate them and identify that and release it, they'll usually quit handling it. But patients that have undersized pins, poor decisions made that aren't comfortable. And when you walk, if it's stable and feels good, you're comfortable. But if when you walk, it feels painful and, hey, this thing's not really good for me, you're not going to be good. Right?
Yep.
Same way.
Okay.
Same way with animals.
I have 2 follow-up questions.
All right.
When the courses were in progress, how long were they? Were they a day course, 2 days?
2.5 days.
2.5 days. Awesome. Thank you. And then, Amy, the microsilver spray, is that something that could be used after an external fixator is placed if it's?
Yeah, it could be. For mostly like the razor burn and skin irritation, I would hesitate to put it on pin sites.
Okay.
But yeah, for skin irritation, especially if they have like some sort of like road rash from being hit by a car or something like that, absolutely. But I would hesitate to put it on a true open wound, because those pins, the pin sites are open. They're not, you can't really close them around a pin or anything like that. So a closed incision is one thing, but those pin sites are open. So I would hesitate to do that.
So if we want to talk, do we have time to kind of ramble
sure
a little bit? Okay, if we want to talk about pin site care, okay,
Yeah.
yes, they're open things. Yes, we do like to keep a clean bandage over them until the magical formula in pin care is 5 to 7 to 10 days. And at that point, those pin tracks become filled with granulation tissue, which if anybody's ever seen a horse with proud flesh, which is just a big wad of granulation tissue, as much headache as that tissue is to deal with, you never see it infected because it's highly vascular. I mean, it's what it is. So highly vascular granulation tissue, healthy bed, makes these pin tracks really resistant to infection. So it's that early day of taking care of them.
So you expect to see that?
We expect to see healthy pin tracks arrive. and we don't quit taking care of them, then we just quit that intensity of it. So, and that's the key to, we've alluded to having big soft tissue wounds for comfort. May I borrow your pencil? Yeah. So I don't know what people can see, but if I stick this pen in my thigh, I just imagine how much that hurts every time I walk because it's doing that. So a good release incision, it glides, it doesn't hurt. So that's easy down here because there's not much, but we don't suture those incisions tight. We leave them on, pack them with thank you, with a bandage, and then they'll get that granulation bed in them, and this big wound kind of becomes nothing, but it's in the appropriate places to make things comfortable, if that makes sense. Okay.
Faye, did you have a question? I saw your hand up.
Yeah, so kind of going back to the reusable implants and thinking of somebody that's just getting into using external fixators. I know at courses I've had doctors ask, well, how do I bill for something? So I'm wondering that, like, for this implants, if a clinic's wanting this stuff back, do they have a deposit that they put on that's refundable if they do come back and the implants are going to be kept at the clinic? Have you ever come across those kind of questions before?
Yes, those kind of questions are very routine, and I would say it varies from practice to practice, and even within a referral practice to referral practice. So 2 or 3 common things I see, and these may be a little bit dated. Concept 1 is we charge our markup for everything we use, and we're done. If we get it back, great. If they don't come back, we don't feel like we've lost anything. There's another concept of we will take our best guesstimate on what we think is going to be reusable if properly cared, and we'll charge you maybe some of that, wear and tear, and average it. And then there's another that actually takes a deposit and then refunds. I think that one's fallen out of favor over the days, because then when they realize something is really trashed or beat up, and then there's kind of an argument, hey, whose fault was that? Why are you not giving me my money back? But I really liked one of the original concepts on that was, let's make the deposit kind of match the films and the recheck, a removal fee. So we can say, hey, this is X number $100 visit today, but it doesn't cost you anything because we're done. So I think it's really kind of falls down into that individual practice management, how they want to charge for things. Do they just want to charge all and be done and not worry about it? Just too many variables to answer. There's one way.
Thank you.
You're welcome.